All right, super. Well, thank you all for coming this afternoon. We're near the tail end of day 2 of the Matrix Summit, and you're at the session entitled Caring for Vulnerable Populations Requiring Skilled Nursing and Rehabilitative Services. So I have 3 subject matter experts in this subject. My name is Carlos Mena. I'm with the Health Resource and Service Administration. I see some familiar faces. Hi, Joe. Good to see you again. And just real quick, because I'm not going to go through all the bios in more detail, but I want to mention with us today, we have Ms. Katie Davis, who's the head of clinical operations at Call 9. And also with us is Dr. Andrew Butler, is a professor of physical therapy in the Lewis College of Nursing and Health Professions at Georgia State University. And lastly is Ms. Diane Kroll, who is the vice president of clinical services for Kuravi Health Incorporated. So before we get started, I do want to quote here a paragraph, a very important paragraph that Dr. Butler had forwarded us to share with you all, because it relates certainly to the slides that you'll be seeing shortly. So, quote, unfortunately, the quality of stroke services for rural patients is suboptimal, and limited access to rehabilitation facilities has a pronounced burden on functional outcomes and quality of life. A recent study demonstrated using logistic modeling that rural stroke survivors were less likely to receive stroke rehabilitation therapy than their urban counterparts. Moreover, with the prevalence of stroke being predicted to increase by almost 25% by 2030, and rural populations being identified as being particularly vulnerable to stroke, there is a great need to develop accessible, cost-effective therapy to minimize functional disability and optimize functional motor recovery for rural stroke survivors. So without further ado, I'll go ahead and pass the microphone to Ms. Davis. Thank you.
Awesome. Thank you, Carlos, and very excited for us all to be here to speak to you today. We're going to start off with some polling. So I'll have you all open your apps and get those ready as I hit our first slide here. So Call 9 is a technology-enabled healthcare service that delivers immediate care to skilled nursing facility patients from the comfort of their own beds. We focus specifically on emergency medicine and palliative care in these facilities. We were founded originally in Silicon Valley, and we were lucky enough to be part of Y Combinator Startup Accelerator in summer of 2015, and subsequently moved our entire team to New York and have built our team out from there ever since. So our first question, we would love to know where you all are from. So are you representing clinical entity, administrative, business, or did you just want to come hang out with us and hear us speak? If our poll doesn't work, we're going to go old-fashioned hands.
Analog version, yeah.
All right, so let's go with hands. How many from clinical? Let's see hands. Awesome. How about administrative? Okay, about 50-50. Who just wanted to come hang out with us? Nice. There we go. Thank you. All right, awesome. So next poll, which we will also go with hands. So there are approximately almost 900,000 hospital beds in the U.S. How many nursing home beds do you think exist? So the population that we all serve is the nursing home population. Do you think it's 500,000? Hands? I see some, yes, absolutely. 750. Couple? 1.1 million. A lot more. 1.7 million. Got 2 that think 1.7. It is 1.7. We have over double the number of nursing home beds in the U.S. than we have hospital beds right now. Rehab stroke care, which is what Andrew is focused on, and unnecessary hospitalizations, what Diane and I are focused on, costs the system approximately $40 billion per year. Who thinks that's true? Who thinks that's false? All right, it is true. So that is obviously a lot of money. So problems that we are trying to tackle. As Carlos read, and as Andrew will tell you more about, almost 800,000 incidents of stroke in the US annually, with 670 or so survivors. 80% of those experience upper extremity impairments, and resulting in about $34 billion to the healthcare system. For Call 9, what we recognized and focused on was this unnecessary hospitalization. So 19% of ambulance trips to hospital originate from skilled nursing facilities, even though skilled nursing facilities make up only 1% of the population. So there's a huge shift there. 2/3 of trips from skilled nursing facilities are thought to be avoidable per CMS. And again, this is resulting in $40 billion on unnecessary costs. And it takes 64 minutes to see a clinician in the emergency department on average after you call 911, which is a long time if you're having an emergency. So what creates this problem in nursing homes? There's a 1 to 20 on a good day in nursing homes, nurse to patient ratio. Diagnostic equipment often is not available. You don't have physicians, nurse practitioners, PAs available 24/7. They may be there during the day in some places. Others, maybe they come once a week to see some of the patients. Maybe they come once a month. So just depends on the population that they're serving. And then obviously all of our hospital systems want to try and push patients out as quickly as possible, rightfully so. Those patients that are still sickest are going to skilled nursing facilities because they can't go home. So this puts a lot of burden on these skilled nursing facilities that weren't always used to caring for a population that was so ill. So Call 9, our mission is do right by the patient and all else will fall into place. We are a venture-backed company. That's how we started as a startup. And our guiding principle has always been focus on the patient, do right there, and we'll figure out the rest. And you'll hear as I go on about some of the challenges that we've had and the reasons that we need to continue to focus on the patient.
In the event of an emergency, our first reaction is to dial 911 for immediate quality care. However, in nursing homes and rehab centers, sending patients to the ER can be costly and takes a considerable toll on the patient's well-being. Every year, millions of patients endure emergency room visits and hospital admissions that could and should be avoided. Instead of bringing patients to the ER, isn't it about time to bring real-time emergency care to the patient's bedside? Call 9 is on a mission to improve patient care by preventing unnecessary hospital visits and providing diagnostics and treatment on-site in nursing homes and rehabs. Assisted by our highly trained on-site first responders who work collaboratively with nursing home staff, Call 9 physicians can examine patients via Call 9's sophisticated technology platform within minutes of an acute event. Call 9 doctors are able to treat multiple patients simultaneously from the comfort of their own homes, delivering superior care at a fraction of the cost, allowing patients to stay in their nursing homes in 80% of Call 9 encounters. Pairing cutting-edge technology with a human touch, Call 9 is transforming emergency care for patients and doctors alike. Join the future of emergency medicine.
So that video gives you a quick overview of what we do, why we do it, how we solve those original problems. We provide this care in nursing homes at their bedside. We put a clinical care specialist who has emergency kind of medical technician or paramedic training on site 24/7 to help the nursing staff. And we have a remote provider team, physicians, nurse practitioners, PAs, and we have shared medical decision making with the primary care team, the family, and the patient, which we found to be incredibly valuable. And then we continue to monitor these patients for the next 24, 72 hours as needed to assure that they're improving and that they're not getting more ill. This next video is one of, and actually I shouldn't say one of, it was our first patient that we saw and treated in one of our nursing homes.
So, oh, you look beautiful. You want to say hi to the people at Central
Hi
Island?
everybody, how you doing? I'm doing good.
Yeah.
Thanks to these gentlemen here. This program, it's fantastic. And it saved my life, really.
Yeah. Mr. D,
Yeah.
it's been a pleasure. This was a really special thing for us, and I'm glad that we could be there with you. And I think you're the first of many patients, and I think your case is really gonna help the world.
I hope so, yeah.
Yeah.
I know it helped me.
It did help. Yeah. Well, you're here talking to us, and the
Yes.
people at Central Island will be there waiting for you when you get back pretty
Okay.
soon. All right. Thanks a lot.
Okay.
Here. Great.
So that was Mr. D. Mr. D was our first patient. We were not planning to launch our service that night. The nurses came up to us and said, "Hey, we've got this really simple patient. I know you guys aren't really ready. Easy one to get you started. He's constipated. We already called the doctor. We are going to give him an enema and we're going to put him to bed. So why don't you just come see if your technology is working, your software, test it out, see what happens." So we saw Mr. D. We were able to pull up his medical records in the facility EMR from our computer system, recognized that he was a diabetic. His respiratory rate was quite fast. For any of the clinicians in the room, diabetic, respiratory rate's fast. He's got some vague abdominal discomfort, kind of pointing to his epigastric area. For any emergency providers in the room, that has heart attack written all over it until proven otherwise. Did a 12-lead EKG at the bedside, uploaded that to the physician that was there remotely, found that Mr. D was having a septal wall MI. And he started to go into respiratory failure, acute pulmonary edema. As we were there at the bedside, able to put him on oxygen, put him on BiPAP, get an ambulance in, get him to the hospital, and saved his life. He otherwise wouldn't have woken up the next morning if they had given him his enema and put him to bed. So I think that's one really great example of the power of telemedicine and the care. There wouldn't have been a doctor there, right? They had already called the PCP, the primary care provider. They'd already gotten the order that they were going to get for this patient. But by being able to visually see that patient, collect those diagnostics, you can really change lives. Slightly ironic that we sent him to the hospital, given our goal of trying to avoid unnecessary hospitalizations. But that's the point, right? Unnecessary hospitalizations. This was a necessary hospitalization, and we'll always, always, always send patients to the hospital that have to go to the hospital. All right, so that jumps us into some of the challenges that we are having, I would say probably across the entire sector. So reimbursement is a huge challenge for all of us. This next video clip is from a Senate Finance hearing just back on March 6, 2019, and thought that it was a great clip to kind of kick us off into this problem.
My question to you is, within the industry, is there an understanding that in many cases patients are, because there's no other option available, sent to an emergency room that are in nursing homes to find out that it was really not necessary for them to be sent to the emergency room, but that was the safest option at the time? Are you looking at ways that you can reduce unnecessary hospitalization?
Yes, we've made reducing hospitalizations one of our center focus points for our quality initiative areas. And I would say that, particularly in the rural areas, the promise of telehealth is great, but as you know, telehealth varies all over the map with that. And I do think that, generally speaking, the nursing home staff I talk to find that when people go to the hospital, they come back usually worse than they left. The acute illness might be treated. The emergency room may address the issue, but the resident really suffers a lot because, as you've heard, these elderly individuals are very frail and have a lot of complications with them. So we think it's important to address that and lower it. I think telehealth definitely plays a role in it. We hear from members all the time which ones, how to work it, and there's a lot of different companies out there. So we would be happy to work with you and your staff to figure out how better to do that.
Is this an issue of just not understanding telehealth, not having it available, not having the right staffing needs in order to deal with this? I appreciate the fact that you've acknowledged a problem. And you'd also acknowledge that by sending the person to the emergency room, it may not even be in their best interest. It's a costly option, by the way, also to our healthcare system, but it may not be in their best healthcare interest. Do we have a regulatory problem that allows you, that is impeding your ability to deal with this issue? Is it a cost issue on staffing? Is it a lack of understanding on how telehealth works? Are there restrictions on telehealth? Where can we assist in helping you solve this problem?
I think there's a number of different ways, and probably giving the time and everything, better if we sit down and talk with your staff on how to do it. But I know that one of the common issues we hear from telehealth is about how they get reimbursed for that time. And I think the current reimbursement system was designed not even prior to telehealth, and how to incorporate that in is one of the challenges that are out there.
So that was Senator Cardin, and we have been working with him as well as Senator Thune very closely, providing technical assistance on something called the RUSH Act. So Call 9 has chosen to see all patients, whether or not we get reimbursed for our services. We are a venture-backed company. We have a little bit of that bandwidth to be able to do it. And we felt that it was in the best interest, again, right, going back to our mission, of our patients to see everyone despite whether or not we are going to get paid. We didn't want to have to choose which patients to see based off of which payers were going to reimburse us, and create that level of confusion. That being said, we are getting to a point where we've been in business for 4 years, and and I'm sure many of you and others, have to start getting paid to be able to continue to operate and survive in this environment. So the RUSH Act will really help improve access to quality care, as Dr. Gifford and then Senator Cardin identified. Most of these patients that are going to the hospitals, when we're talking to the staff and when we're seeing them, they're coming back worse than when they went to the hospital. Yes, maybe that acute illness was treated, but they got delirious in the hospital. Then they got sedated. Then they got their UTI, and then they get back to the SNF, and oh, by the way, they have their hospital-acquired pneumonia now. So this is a very, very large kind of problem to the healthcare system. And I'd say the RUSH Act is really, it's moving away from fee-for-service, looking towards value-based care, allowing for Medicare reimbursement with this population, which is obviously the majority of the population. And truly, truly tip of the spear legislation. Ideally, if something like this is to get introduced and passes, it's helpful for everybody. It shows that we're making progress, that we're in a place where we have some opportunity for value-based medicine and reimbursement with Medicare for this population without the current rule structure. And truly, I think as it identifies there, aligns everybody. So aligning your clinical groups, your facilities to be able to improve care for patients. So this, on the left, is Charlie Durdaller. That's Mr. D's son. And he was able to speak about the RUSH Act, at a hearing recently and truly identified that when Call 9 was there, we were able to help save his dad's life and give him even just 6 more months with his father. And I think that really shows the power of telemedicine. Before we were there, he also identified that patients were just going to the hospital unnecessarily. It's not anyone's fault. The staff can't handle it there. They're not equipped to do so. They don't have the support. Couple quick testimonials. Another patient, if Call 9 were not here, I wouldn't be either. They saved my life, to say the least. And really the other side of our work. Your compassion, guidance throughout this time has been invaluable. The fact that my mother's death was peaceful and that every one of our concerns was addressed in real time is a blessing. So that's the kind of the palliative care aspect that we do of our work, making sure that we can care for patients in their beds. So a couple of key learnings from what we have found, and after we all speak briefly about our organizations, we will take questions. So first one, make something people need and make something people want. These are really Y Combinator teachings. They are all over our office. If you make something people need and you make something people want, inherently you will have a successful entity. Addressing the quadruple aim. We have struggled with this a little bit. So you have to create systems that provide value to patients and families, the clinical team, the healthcare system, and the population. We are currently focused a lot on our clinical team and making sure that our systems are supporting them as well. It's not helpful if we're getting to the patients, we're getting to the families, we're getting to this population, and we're helping the system if our clinicians are burning out and aren't able to sustain the work. So they need appropriate reimbursements and structure as well to make this successful. And third, reimbursement. Reimbursement continues to be a challenge as well as an opportunity for what we are all doing.
Great, thanks, Katie. I guess we're going to wait until the end for questions. Oh, can I get the clicker?
Yes.
Thanks, that was fantastic. And I've first of all, I want to thank the organizers and my colleagues. It's really been fun working with them over the period. So I was invited. My name is Andy Butler, and I'm a professor at Georgia State University. I'm a neuroscientist and a physical therapist, and this journey will be really about rehabilitation of a person who has a stroke. And again, going back to Katie's slide about sort of pain points and a need, and that's what helped develop this. So this was developed as a TED Talk. So as you know, TED Talks are sort of low on a lot of slides, but a lot more talk. So if you'll follow through that journey, that's where we'll start. So how did you start your day? Imagine that you started your day like mine. You probably rolled over and pushed the alarm clock, or then went to the restroom, and maybe went to the kitchen and picked up the pot of coffee and poured a cup of coffee and sat there and drank it. Maybe you listened to the radio or read the newspaper, then went into the bathroom, took a shower, used your hands and brushed your teeth, and then maybe went on to get into your car and drive to work or go to the bus. That's sort of a typical day that most of us have. But imagine that you couldn't do that. That when you reached over and grabbed for the radio, you couldn't do that, or that you couldn't brush your own teeth, or that you couldn't button the buttons on your shirt because you'd had a stroke. And many of you people said that, many of the folks in the audience said that they were associated with clinicians. And so people who have a stroke have impairments. They have paralyzed arms and legs, and they can't talk very well. And so imagine you can't do that. And so that was sort of the need that we had. And I'm going to start the story off with Deb, who had this need. So can I push it?
If you hit the next, it should play.
Go ahead.
I guess I kind of stumbled. My arm went limp. And I remember talking really slow. And I said to myself, you know, Deb, you're okay. Go get a glass of water. This is going to go. One guy said, Deborah, you're going to have to go to the hospital. And, you know, when you're so independent, you're such an energized, lively, zest for life person, one day and you wake up and you say, what the happened to me? Someone's taking care of all my personal needs. It's just like your whole world. It's hard to put an arm around or grasp what happened to you. You're this little independent person and you're having to have people get you in and out of bed. I had an opportunity to meet these.
So as you can see, that's Deb, and she had certain needs, and that's where this innovation came in. Again, I have no conflict. I'm a university professor. This device came out of a spin-off out of our lab and through intellectual property and things like that. But yeah, the pain point was that there are no good rehabilitation solutions. It's the same solutions that have been used for years. Patients will go in and go to a rehabilitation center, maybe get an hour of therapy 3 times a week, and it's dependent upon the therapist's time, not your time point. Well, early in my career, I did work on something that had a lot of evidence, and it was based upon, it's called constraint-induced therapy. Has anybody ever heard of that? It's based upon a really simple theory. Remember when you're a kid, there was someone in your class that had a weak eye. So they would put a patch over the strong eye and force that weak eye to be used. Well, it's the same idea with stroke. And about 15 years ago, we took this idea at Emory, and we would constrain the good limb and force someone to use the not so good limb. 8 hours a day for 2 weeks in a row, one-on-one therapy. We did a number of clinical trials at Emory, at the Cleveland Clinic, at the University of Southern California, and it worked. We've had good outcomes, but no one was ever going to reimburse one-on-one therapy for 2 weeks in a row up to 8 hours a day. So we started to work with a robotics company and some engineers. And we said, you know, we want to use these ideas of this constraint-induced therapy and develop an exoskeleton, something that can go over the arm or the leg and help a person exercise. So just like everybody's seen that movie, The Iron Man. The Iron Man gets in a suit and has these superhuman strengths. So that's what we wanted. We wanted to develop an exoskeleton that if a person couldn't move, that the robot would help them, right? So if a person couldn't move at all, the robot would help them 100%. And as the person got better, the robot would work less, and you would work more. Again, using the same thing that Google and Amazon uses with artificial intelligence and machine learning. It learns as you get better. And so those are some of the pain points of that. And let me just show you the device, and then we'll talk about the history and the implementation of this. Whoops. Is there one there?
Welcome to the Hand Mentor Pro Rehabilitation System. The Hand Mentor Pro is designed to help stroke survivors improve range of motion, strengthen, and enhance motor function, helping to reduce impairment and improving quality of life for the patient.
Some of the patients that I've been working with have described to me improvements in their upper extremity function. They're able to use their arms better, use their hands better. They're reporting less depressive symptoms.
And I definitely am seeing results, because I find that my hands stretch, because in the morning it has a stretching exercise that you go through that kind of beats some of that spasticity. And just the repetition and the awareness of this hand that it's here and that it can work. I see a lot more change in the upward movement than the down.
Stroke survivors who are experiencing paralysis or paresis as a result of stroke will be guided through various exercises incorporating fun, interactive video games that help stretch and safely guide you through upper limb rehabilitation.
One of the benefits of the Hand Mentor is that it actually is very easy to use. It's originally designed to be used without assistance, and so we find that our stroke survivors are able to actually use this independently, or often they're able to use this independently. The device was designed such that there was no complicated donning and doffing process, and the user interface is really quite user-friendly. It's a touch screen. You don't have to be really computer savvy to operate it. It's very user-friendly.
One of the major benefits to the Hand Mentor is that it was designed with home use in mind, so you can complete exercises right in your own home with a flexible schedule you arrange that fits your lifestyle.
I like having it at home because any time that I want to use it, it's there. And I think the real benefit of this is the more you use it, the repetition, the more you're going to benefit.
The Hand Mentor is a wonderful addition to the care that I provide in the clinic. We're finding that it increases the access to rehabilitation. It makes it easier for our patients to get access to the therapy. It also gives them increased flexibility with the scheduling.
If you would like more information on the Hand or Foot Mentor, please visit www.ruralhealth.va.gov.
So there's a lot to unpack in that video. We did a number of the early clinical trials, and that's sponsored by the Office of Rural Health at the VA. So we did a number of the early clinical trials in the clinic. People would drive in, they'd use the robot and exercise for an hour, and then they'd go home. But another pain point was they said, I don't like driving in. I don't like paying for parking. This was at Emory University Hospital in Atlanta. There was never any parking. It was confusing. So again, we worked with the engineers to develop the first, as far as we know, stroke telerobotic rehabilitation system. So it's a store and forward system. Think of it as a really fancy Fitbit. It's asynchronous. They do their exercises. And in the model that at the VA, the therapist, the neurologist will refer the patient, and then the therapist can follow them up, just like you look on the dashboard of your Fitbit and you can see any number of things, how many repetitions they do, the exercises they do. But what we found, we have a little different. The VA was really interested in 4 things. Can you improve function? We did that. Can you improve access? Specifically, the Office of Rural Health said, as you know, there's a lack of resources for rural veterans. Can you improve access? Can you improve patient satisfaction? And can you decrease cost? And so, and I'm going to talk about this in the next slide, we could do that all with this system. So I want to give a little bit of a history because Catherine and I were talking early. In the university world, in a big healthcare system like the VA, we chose the VA for a number of the pain points that Catherine talked about. The VA is not necessarily, and I mean that's a caveat, not necessarily interested in the payment, right? They're interested in other outcomes. They're interested in access. And they were very interested in outcomes and no-shows. They were very interested in reducing the amount of no-shows, and we did that. But so we started it as a field test back in 2010 and 2011 in metropolitan Atlanta. And we tested about 20 people in about a year and a half or 2 years. And again, we found about an 80% change in functional activity of the lower limb and functional activity of the upper limb. Some people who were not community ambulators became community ambulators just by doing these exercises at home. They increased their dose. So, typically when you get a medication, somebody says, take this pill 2 or 3 times a day. We found in our data that people were completely underdosed in terms of their rehabilitation. And so we were able to increase their dose up to 2 hours a day. They do it 10 minutes in the morning, another 20 minutes in the afternoon, another 30 minutes in the afternoon, and they loved it. And so they increased their dose, and their outcomes became better. We increased, the patients loved it. The patient satisfaction was 80 or 90%. The only complaint they had is that the games got a little bit boring. So again, you had to work with the coders to develop some new games. We increased access. Some of these people had exhausted all of their resources, but they had been discharged home because they could do all the things that the functional independence measure says that they can do, but they still were not functioning in their community. So we increased that. And then cost. In the VA system, you get reimbursed for coming back to the hospital and doing your rehabilitation. Why did we choose the VA system? Because again, one of the things that Catherine talked about, it's licensure, and it's treating across state lines. And if you're a therapist in Georgia, you are a credentialed therapist in the VA system. And essentially, you can treat a person in Alabama or Oklahoma. And so that's where we went next. We wanted to expand the stroke telerehabilitation to rural veterans. The Office of Rural Health supported us for about 3 years, and they said, we don't want you to only do it in the urban setting, but we want you to do it in the community-based outpatient clinics in rural Georgia and then Alabama. And that, we, again, found those 4 outcomes. We were focusing on those things. And they said, okay, so now, now that you've done it in an urban area, in a rural area, we want you to implement this in other areas. And that's where the tricky part's been, right? I'm a neuroscientist and a physical therapist. I don't know anything about implementation science. And for those that you do, it's not so easy to implement things all the time. And I see some heads that are nodding yes. So we expanded to Birmingham, Alabama, Oklahoma City, Billings, Montana, and maintained it in Atlanta. And we were successful in all of them except Montana. And the next slide will we sort of debriefed afterwards, and it may help the group why we weren't successful. And so because we weren't successful in implementing it across the United States, we scaled back. And we said, okay, let's just do it in the region. So in the VA parlance, Vision 7 is the southeast region of that. And we're also trying to expand it into the civilian world. And there are certain challenges in expanding it into the civilian world. Some Catherine already mentioned in terms of reimbursement and other sorts of things like that. But this is the 5-step process that we went through in terms of our implementation. First of all, we identified it was a promising practice. I talked about those clinical trials we'd done. Clinical trials are done, well, sort of in a vacuum, right? And they have a lot of rules and regulations, and they were successful, but it was a promising practice. The next thing we had to do to implement this is we had to find local champions. And that's really important, to find not only the therapists and the physicians, but you had to have the people in biomedical engineering, and the people in HR, in electronic medical records. The reason we were not successful in Montana, the physicians loved it, the patients loved it, the therapists loved it, the business administrator did not. And so it failed, right? So, and it failed miserably. So much that we just had to take the robots back and redistribute them. Adapt it and replicate it. We did it in one spot very well, and then we replicated it at other spots. And we had to establish consistency and standardization. So we painstakingly, I'm at a university, so we had students, we painstakingly created manuals of procedures, templates for electronic medical records. In the VA, it's called CPRS. And we created those templates that then the other sites could use. Of course, they had to tweak them. We created those videos. Those are all students in my lab. They're actual therapists, and then, of course, the patient, Deb. But we created those videos, and there's a whole host of these about how to don and doff and how to use the devices, how to plug it in. 2 or 3 hours of these videos. Why? So it's consistently deployed, implemented across all of these different sites. And then you have to sustain and improve. And sustainment is always a challenge, right? How do you pay for it? And again, it's not necessarily, some places aren't necessarily interested in revenue generation. The VA was very interested in access and reducing no-shows. So we, as our team, we had to direct our implementation plan towards that. Now, in the civilian world, we're trying to work with Grady Hospital, which is a big quaternary care center in downtown Atlanta. They have different needs, and so we're trying to do that. But that is I'm a professor, so we sort of have a theoretical construct that we sort of developed and used that. It's a big team. I don't care if you look at all the individual people, but it's made up of clinicians and therapists. We had a healthcare economist, many students, PhD students, and other sorts of clinical doctoral students, champions at the outpatient clinics, teams in Oklahoma City that are made up of physicians and nurses and occupational therapists, national partners, the national VA. Again, I can't emphasize enough to have those champions, regional directors. They assigned us an entire quality enhancement group out of Indianapolis that just worked on the implementation. So again, we thought about this. And But it doesn't just take a big team. What really drives these new and novel things, especially telemedicine and telerehab in the home, is the patient and the optimism that a patient has. And I think Deb says it best.
Oh, I knew I was going to beat this. I knew I was. I knew that I'm a very strong person, and I knew I wasn't going to let this keep me down. I was scared. I mean, I was in a big rehab. I was in Macon, Georgia. It was there was 40 people in the rehab area, and it was very loud. I had a lot of anxiety, and that's, I think, what created the stroke. But I will remember this. I was in there for 30 days in the rehab. I was at a window, and every day that sun would come through, and I just prayed to God. I said, God, get me through this. Just get me through this day. I just took it one day at a time. You know, just one small accomplishment at a time. But I was scared to death. Scared to death. It's, you know, a lot of these things in this happen to me I don't control, but I can control this. When someone offers you an opportunity like this, go for it. You have nothing to lose, nothing. And as you know, we have a little bit of time on our hands. Use it. It just makes me feel good that I'm having control. Maybe I get my hand back a little bit more of my life. Absolutely, 190%. Opportunity. You have nothing but to gain by doing it. Don't even second guess it. Go for it. Run. Go for it. And I truly mean that too.
So Catherine had Mr. D, I have Ms. D, so that is just a brief explanation. And all these things are published. We have half a dozen published papers, and you can always come up to me and talk to me afterwards about all the detail. We're looking for collaborations, especially in the civilian world, to see how we can test this model. And that's all I have. Thank you very much.
No, it's okay. Good for me. We'll advance the slides. That would be great. Hi, everybody. Thank you so much for being here, and I truly appreciate the opportunity to speak with you. It is late in the day. If anybody wants to stretch an arm or twist an ankle a little bit, I totally understand. My name is Diane Kroll. I'm a nurse practitioner, and I get to be a part of a company that actually makes such an amazing difference in people's lives. And not only that, but it helps every single stakeholder involved in the process. Everybody from the patient all the way down to the insurance company and everybody in between. I currently work for a company called Karavi, and this is much of the work that we're doing, but there are probably 5 or 6 different companies, such as Katie's Call 9, in the nursing home space right now doing this. So this is just an example of what one company is doing. I do want to give you, go ahead. I'm going to give you a little bit of a background, tell you about what we're doing, go over some of the benefits of telemedicine in nursing homes, and let you know the kind of service offerings that we at Karavi offer. Okay? So when I've talked to other people, it's interesting, we use the words, but we don't always define them, and I just want to make sure we're all on the same page. Some of you may be very experienced and very knowledgeable, and others may be relatively new. So I'm just going to go through some questions about telemedicine and give you some background. Okay. The 2 words that we often hear are telemedicine and telehealth, and even this is up for discussion. So telehealth is just that general term about the electronic transfer of medical information. It can be clinical, educational, and administrative. Telemedicine is when you use something to provide care and impact that patient care. So what we're practicing is telemedicine. Electronic records, mostly that's telehealth. There's different kinds of telemedicine. Store and forward was some of the very first in nursing homes. Dermatologists often did this. Somebody would take a picture of a wound and then send that picture to the dermatologist. That's telemedicine. What we're doing, video conferencing, is synchronous. It happens right now. It happens live. So the physician will be in one location, the patient will be in another, and they'll exchange information through video, audio and video. Remote patient monitoring, some of the ways that we can monitor people's positions in bed. whether or not what their weights are, their blood pressure, and some of the continuing monitoring is going on in nursing homes as well. And then there's mobile health. Everybody's familiar with the apps. You can do an app and get information sent through that. Telemedicine is used in so many places, and it's wonderful here at in this kind of a setting where you get to talk to people that are doing it in different locations besides just what I'm used to. Hospitals, schools, prisons. It's interesting, in prisons, you know, until I did some research, you don't realize the cost of sending a prisoner to the hospital. Not just the ambulance itself, but then the folks that have to accompany them, and then there's repeat visits back and forth. So the care that they can provide in prisons and the cost we can save is very significant. Certainly there's CVS, Giants, Kroger's, home care, the outpatient clinics, nursing facilities, even the space station, right? That's how they get their care, is telemedicine up in space. The different uses, it can be acute care, which is much of what we do, chronic disease management, those follow-ups. There's one group that I know of in South Dakota that helps children who have diabetes, and every other scheduled visit they can do through telemedicine. It can save the parents a day of travel, and certainly it's a lot more convenient for the kids. Scheduled exams, annual physicals, sports physicals, and certainly sports injuries. People that are doing sports and get injured, they can use telemedicine to take care of folks on the fields. This is actually a picture of the first, what's often agreed to be the first instance of telemedicine. So this is the original EKG. One arm, one leg in salt water, and a signal being transmitted to the machine. This is in the early 1900s. So this is our first use of telemedicine. Okay. To actually take care of somebody through telemedicine, it occurred in Australia in 1927. They actually helped to get an injured miner off of an island. These are some dates. Don't need to read all the details, but things have been started. It was radiology images were transferred 24 miles, and that occurred in Pennsylvania. Excuse me, University of Nebraska, two-way interactive television, 1959. In 1960, this was interesting to me, NASA, the US, and the Indian Health Service worked with Lockheed Martin to do a joint program. It's an interesting combination. And then in 64, Norfolk State Hospital transferred, did speech therapy at 112 miles distance. In nursing facilities, there was a Boston nursing home project in 1979, and followed up by 1997, there was use of the store and forward with video telemedicine. And right now in 2019, there's at least 6 nursing facilities, healthcare providers that are working through telemedicine. We cover hundreds of facilities, and thousands of patients have this option of care. Here at Karavi, our goal is to truly work to transform the delivery of care in nursing homes through different telemedicine solutions. We try to help the nursing homes to work at a higher level of care, so that if someone does require IV therapy, if they require immediate care for an acute issue, many times we're able to help them provide that, working with the nurses to provide the support they need. It elevates their level of care, and people can be treated on site. As Katie so well described, it's so important to avoid these hospitalizations. I had a practice in a nursing home at one point in Connecticut as nurse practitioners. We could do that. And we sent a person to the hospital, and somebody forgot to take away and leave the artificial leg. So they actually lost a leg in the nursing home hospital. And of course, nobody wanted to pay for that, so it was very challenging to have that person come back and be ambulatory again if they were missing their prosthesis. You lose dentures, those are also not replaceable, so you have people that come back and they have to end up on puree diets. Not only to mention the MRSA, the C. diff, and everything else. So anything we can do to keep them and treat them safely in-house, I think is really important to do. It definitely helps to improve the residents and the patient, that experience. The trip in the ambulance can be frightening for people. And then in the hospital, they're often not the priority. In the emergency room, they're truly not the highest risk, so they often end up waiting a while. It's a way to certainly efficiently treat and follow up with them. We've also had facilities let us know that we've helped to increase their clinical outcomes. There's a relationship can be improved with the hospitals or referral sources. ACOs really appreciate this. We really can help you to keep people out of the hospital. Hospitals like that too, so it can improve the overall financial situation for everybody. I'm missing some words, it's okay. That's okay. This is a picture of what it looks like. So that would be the telemedicine unit, with the speaker there and the screen. It's a nice large screen, so the patients see the physician on the other side or the nurse practitioner, and they can really, it looks like a real person. It's not a little tiny picture, it's an actual nice sized picture. And they can talk to back and forth. The speaker is right there. They can move it closer if the person is hard of hearing. We work from 6 p.m. to 6 a.m. Monday to Thursday, and then from Friday night at 6 o'clock, they cover until Monday morning at 6 a.m. So it's 108 hours a week plus 6 major holidays. And if you can have a physician or a nurse practitioner come to a bedside at 2 a.m. on a Sunday morning and talk to you live, to me, that's a wonderful, wonderful thing. Another thing, currently, because the facilities pay us a flat rate per month, we pay our doctors a flat rate per week. The patients have no cost. We currently don't do billing. We do also certainly work with the attending clinicians, the NPs and the physicians. We're happy to speak with them at the time of the encounter, or we interact the next business day, just to let them know what's been going on. Okay, that's good. This is just a schematic to show you the hours that we work, and we're in the kind of the solid green, and the not covered is the other one. So we're covered more times than the regular attending folks do. It's harder and harder, having worked in a nursing home, it's harder and harder to make sure you have that kind of coverage. It can be difficult when folks are covering multiple facilities. They can't always be in any one place. So we really truly work with them and supplement. Our goal is to treat them on site and then to hand over that care in the morning. We're not looking to become primary caregivers. Okay. This is how the service works. Currently, we offer either an all-call model, where we'll take any calls during our hours of business, or a change of condition. So this would describe the change of condition. So the nurse notices a change of condition. They get some background information on the patient, make sure they have current vital signs, pick up the phone. They dial our number and they speak directly to the doctor. They give a report and the doctor says, wonderful, thank you, maybe ask some more questions. Then they say, okay, I'll meet you in the room in 10 minutes. The nurse takes the telemedicine unit to the bedside. The physician will go in and look at the patient's electronic record from the facility to get some more background information. They meet in the room, use the digital stethoscope to do an exam, talk to the patient, introduce them, make sure they have any questions that are answered. They'll work with the nurse to develop a plan of care. The nurse begins to implement those orders, and hopefully we treat them on site. We have an electronic record we create notes in, and those notes are sent to the facility. They're all can be sent to the attending physician, and then there'll be follow-up back and forth. Again, our goal is to treat them there on site. Okay. These are some of the offerings that we also offer at Karavi. In addition to providing the physicians who are available to work through the units, some of the companies have also asked us if they could bring their own providers. So perhaps during the daytime, they want the nurse practitioners to use those telemedicine units, and that's fine. We're happy to work with them. We do have psychiatry available, telepsych in Pennsylvania, and our units are able to have EKGs. So there's really easy to follow diagrams to let the nurses know where to put the electrodes. And then the EKGs are sent. We have a cardiologist available who reads them within 1 hour. We certainly are, we're working now, I'm very excited, we're doing some advanced care planning, an actual pilot where we're working with a company that does videos where we can offer people the opportunity to create a, I'm very sorry, I'm dry, create a video saying what they want for their advanced care planning, and that becomes part of their medical record. So we'll work with them to do that. And we're also working to integrate with point-click care. That's the documentation system, electronic record used in many nursing homes. And we're working to help to integrate our electronic record with that one. We're working on it. Okay. This is a kind of a diagram or a picture of the carts that we use. There's a regular cart here, the battery down on the bottom. Up on top is the camera. Then we have a wound camera that they also can use. It's very easy. That just helps them to highlight areas that they use with wounds. There's also a digital stethoscope, and they can hear very well her heart and lung sounds, abdominal sounds, whatever you would need to do. It's very nice because the nurses also hear exactly what the physician, oh, thank you, Carlos. The nurses hear what the doctors hear. We also tried very hard to engage with nurse practitioners and physicians who enjoy teaching, because we want to make sure that when the nurses have time and the interest, that they'll teach them those things. They'll let them know about what those heart and lung sounds mean. So they certainly engage in that. We also encourage them to be willing to discuss with and explain what their orders are, to try to help the nurses be able to function at a higher level even when they're not working with us. So the idea is to make sure that we have nice people that the nurses want to call, that can provide the care that the patient needs, and then be willing to talk to and meet with the nurses and be collaborative in their approach. Okay. This is talking about our all calls model. Some of the things that we do would be to order admission order verifications. I used to do this myself in the nursing homes. The attending physician, the physician of record, needs to do the actual care plan development and to do that first initial visit, and those can't be done through telemedicine. But we can help the nurse and just verify the admission orders. That is something that we can do. We can also help with therapy requests or consultations if those are needed. Some of the other things, if there's a test result that the nurses need help with, then we can help with that. We can also order something if something has to be done or repeated. We can help them with medications, certainly any non-medication treatment orders that need to be adjusted. And our doctors, unfortunately, if somebody has passed away, they can confirm that the person has died. Some of the acute changes of condition that we handle would be shortness of breath, which can be exacerbations of COPD, heart failure. Chest pain often is GI in nature or costochondritis, so it's musculoskeletal. It's not necessarily chest pain. If someone has fallen, there's the physicians you can take the unit right to where the person is, and you don't have to move them. And they can walk you through a musculoskeletal exam there, and perhaps maybe it's more fear and anxiety than actual bone fractures. So that time spent with the physician can really help to not send everybody into the hospital even though they've fallen. Those are some of the examples of some of the kind of visits we do. This is just the EKG that we offer. So you can do that within 1 hour, as I said. Okay. And the advanced care planning, we work with the Institute on Healthcare Directives. It's a really very thoughtful approach to making sure that whatever it is the person wants done is recorded and available. Another thing that we're working on is Karavi on the go, so that we'll have folks, people that do the telemedicine will live in the community, and if there is a need, then they can bring this Karavi on the go box to the nursing home and take care of them in site. So that it's just an ad needed, and that would be also for change of condition. But that would help you if you do have a situation where the nurses don't have time or the staffing is an issue, but you can still help to make sure people are treated on site. That just shows you the inside of it. It's a development. We have it in one facility, and we're always tweaking things, making sure it's better. So here's some of our results. So far, we've had over 24,000 encounters. Isn't that amazing? 24,000 times we've helped to impact people's lives. We've been around for over 7 years. currently in 13 states and close to 70 facilities. We, the folks that are treated by the Karavi physicians, so that we recently merged, Triple Care and Karavi merged, and the folks that were treated by the Karavi group, they're geriatricians focused just primarily in Pennsylvania, and they have a 96% treat and place rate. Approximately 40% of those visits are also found to directly avoid a hospitalization. Overall, between our two companies, we have over 8,000 avoided hospitalizations and no lawsuits on either side. Isn't that nice? So it does help to save transportation costs, especially if they're Medicare A covered folks and the facilities are paying for those transportation costs. Readmission costs, which not only are financial but physical for the patients and families. Certainly the reimbursements are always a concern. The facilities lose out money when people aren't there, as you all know. And staff time. You know, it does take time to take care of sick people in nursing homes, but it also takes a whole lot of time to readmit people and to admit new people in. So if we can treat them there and get the nurses to understand how to do that, as they do it more, they definitely have, they get better at it and they get more comfortable with it. So it's like anything new, we work with you to make sure that they understand it and provide support for that. We have, oops, I'm sorry, I'm just gonna let you know it's over, just go back one slide. $30+ million in revenue retention for SNFs. We, as Triple Care, the other company, we did a study in a Brooklyn nursing home, and in 1 year's time, we helped avoid just over 90 rehospitalizations. And based on the monies that the facility, the financials that they gave us, it helped to save $1.5 million that 1 year. And if you can help save money and you can also take really good care of people, I think it's a wonderful thing. Thank you so much.
Well, I want to give a special thank you to our guest speakers, some superb presentations from each of you. Thank you very much. And I want to dedicate the rest of our time. We have about 10 or so minutes for a few questions from the audience.
Chris, do these work? Hi. Those were three wonderful presentations. I have two questions for you about Karavi. The first question is on the EKGs. How do they compare those to prior EKG?
If they have them available in the charts, yes, we do ask them to send over. If some facilities still only have paper charts and some have electronic, whichever form the EKG is, that we have them fax us to us and the doctors can look at them there.
Yeah.
If it's in the electronic record, our doctors can just go in and look at them.
So they would have access to the
Yes.
appropriate electronic platform. So the second question had to do with the savings, which sounded impressive. Was that net of the cost of the service?
Yes,
Yeah.
yeah, it was. And that first year we were at, it was actually Cobble Hills, the name of the facility. And it was the first year it was a grant by a foundation in New York. And then after that, they've continued with us for 3 more years. So even after the funding was up, they still kept paying the bill.
Yeah, because it was a good business proposition. Do you happen to know what the ROI was for that?
I don't. I can get that for you, but I don't know what that is.
That'd be great.
We usually find that if we can help keep 2 people out of the hospital in any given month, it covers the cost of the program.
Interesting. Thank you. Thank
You're
you. Very,
welcome.
very cool program.
Thank you. Nice to meet Laura.
Actually, I'm have a question for someone else, but we have Karavi system in 3 of our centers, one in two in rural areas, and we love them, so they're good folks.
Same here, Laura, same here.
I have a question about the hand mentor. Is that appropriate for folks who have cognitive impairment, or can you use it with a caregiver?
Yeah, that's a really good question. So that's something we found in some of our pilot data, that they have to play these games, right? And so oftentimes, in the Veterans Administration, it's a veteran, and his wife says, "Oh yeah, he'll use it," but he goes home and he was cognitively impaired. So what we did is then again, I have graduate students, and we went back and looked at some of those cognitive impairments, and you have to have a certain level of cognition in order to do that and understand why you're doing them. Or then it's just a passive machine. I talked about those early studies on brain plasticity, how the brain changes, and it's not only the repetitions of movements, but you have to figure out how to win the games, and that's what really helps change your mind, if you will, and train your mind. And so, yeah, they have to have a certain level of cognition to do it.
And a follow-up question, is there a sweet spot about when you initiate the treatment? Because I think about in our skilled nursing centers, the folks that have already developed the
Contractures.
Yeah, you're absolutely right. So the answer is we don't know yet, but and I'll talk about what we're sort of doing in our lab, but you have to have a minimum amount of movement. So it comes from these clinical trials in the constraint-induced therapy. You have to have about 10 degrees of extension in your wrist and about 10 degrees extension of your fingers. You can have had Botox or other things, but what we're doing, I mentioned the Amazon Alexa and Google and all those things that uses machine learning. So what we're doing with the company, we're taking all of that anonymized data, and then we're looking at, for lack of a better term, prediction of what those factors may be for personalized medicine. So everybody may not be the same. You may have a certain functional level, you may be a certain age, your stroke may be in a certain place, right? So we're trying to gather all this anonymized data, and then through the university, then we put them through these machine learning algorithms. I don't mean to get too technical, but then it can help predict who this will work for. So essentially, it's going to be the largest clinical trial anyone's ever done. Now, Apple does that already, right, with us every single day, and so does Mr. Google. But we're gonna tell people that we're collecting this anonymized data, and so that's what we're trying to work with the company. Again, the company spun off, and they're a startup like these guys, but I'm still an academic. I have a good job. I'm not going to quit that. Good questions, though.
Yes, I'm a physical therapist from Kentucky, and it's sort of related to the third question on the screen there with the RUSH Act. And I don't know if it's beyond the purview of your presentation, but it seems like if you're going to pass an act about telehealth, why just skilled nursing? Why not home health and inpatient rehab, for that matter, to permit the same kind of technology being used for the same kinds of reasons?
Good question. So I think for any of those that have experience with government, our process thus far, even just focusing on SNFs, has been quite some time, right? So add in then home care, all of the different stakeholders there, the red lines that go with it. We really wanted to focus on something that we thought we could accomplish, not bite off more than we could necessarily chew, and use this as, like I said, kind of that launching point to then have lots of others turn back and say, hey, you identified that this was good for nursing homes. All right, what's next? Like home care, et cetera. And I think there was a question specifically about, has it been introduced to Senate and House? We're hoping for Senate and House introduction within the next couple of weeks, is the hope.
Is it passed in the Senate?
No, so it's going to be introduced at the same time to both. And then hopefully it'll be pushed for a CBO score. I can grab it for you. Yeah. You can also go to rushact.org. And it has lots of more information.
I have a question about a challenge that we encountered building telemedicine programs to skilled nursing facilities. And these were rural facilities that didn't have, a lot of resources and things like that. And I think one of the problems that has affected our program is the high turnover in these facilities, where staff will get trained in how to do clinical presentations through telemedicine, and then they leave, and that maybe the new staff coming in either don't want to use the equipment, or sometimes the administration changes and top
Yes.
management doesn't want to allow them to take the time to get additional training? And I'm just wondering, how have you experienced those sorts of challenges, and how have you dealt with it?
You go first.
Yeah, we have, for sure. But part of what we've done is to try to make sure that the system is user-friendly, so that you don't need an awful lot of training to use it. And when they call that toll-free number and they first speak with the physicians can walk them through everything else. So the idea is to make sure that instead of calling an attending physician who's just going to say, send them to the hospital, you'll get somebody right away, they'll answer your question, and they'll let you know what to do if you haven't done it. We also provide a train-the-trainer program, so that when anybody is a new hire, we ask them to include it in their orientation. We also provide follow-ups to that, so if the trainer leaves, then we'll retrain them. So it's a matter of making sure there's somebody in the facility that takes almost ownership, that you can go to as the person to make sure that people are calling, and have that star person just kind of guide it in the facility. We try very hard to make sure it becomes, and this is certainly a really big challenge, but have it become part of that culture. And once you can have a few of the nurses have really good experience, then it kind of like takes off. So it's always about getting it used initially, and then making sure that it's easy to use, that it meets the need of the nurse, to make sure that they do provide the kind of care the nurses need. And then just try your best to keep it as simple as you can, so that anybody, regardless of they're a new nurse or if they're an agency nurse or a travel nurse, all they have to know to do is to call that 800 number. That's what we've tried to do.
There's another question up there for, I think, each of you. I know Andrew and I, we talked about this briefly, but how are you all dealing with the cross-state licensure issues?
So for us, we have had to have all of our providers obviously licensed in the states where we're practicing, and we have just gone old-fashioned of submitting licenses. Unfortunately, we haven't found the magic key. We did recognize early on that we did need to hire a credentialing person. For those that work with providers, some aren't the fastest in getting their credentialing paperwork done. So we literally have had one of our credentialing folks help them with the application to move it forward as fast as possible.
It's interesting. When I started this about 5 years ago, few doctors had more than one or two licenses. But now, as more people are already interested and they've already done some on their own, we'll speak with people that have 7 or 8 licenses even before they come to us. So people are certainly engaged more and are less afraid of it, and physicians are having multiple licenses as it is. We've had some benefits from the Interstate Compact, the licensing compact. When we have someone in Wisconsin and they need to get licensed in Illinois, that can take less than a month now. The same for, and it depends. It's really good when people are part of that. It doesn't cost any less, but you can cut down on the time if they're licensed in one of those other states. So it's also and it's not just the license, it's also the DEA. So for each state in which they're licensed, they need a corresponding DEA. So once you get them licensed and they meet all those requirements, then you apply for the DEA.
Yeah, and we're working with our state senators, just like Catherine showed, to bring these bills. In Georgia, they're bringing up state reciprocity agreements between them, and it makes sense for them to do it. So again, through the political action committees and things like that, the technologies move a lot faster than the legislation, but we'll take baby steps. Sir.
I have a related question. As a physician who only ever practiced in one state as a civilian, I'm kind of curious as to, and I run a CBO for our healthcare system. How do you handle the liability insurance for somebody who's licensed in, say, a dozen states? How does that work? I just never thought of it until this afternoon. I'm very curious.
We carry the insurance for all of the physicians that work with us. We cover under our own, and our premiums are actually lower than a regular family practice. Part of that is because of the documentation that we do for every single call that we make. We have documentation for it, and they get to see the patients. So the rates are lower than for a regular family practice.
Yeah, we also do the same. We license we insure all of our clinicians, and we use specifically pro insurance. So if you guys are looking into different companies, they've worked well for us. Similarly, we took, instead of the family practice approach, the emergency medicine approach. We carry just as much coverage as you would in the emergency department, yet, and actually more in some cases, but our premiums are significantly lower. And from the EM perspective, that's because you're not discharging home. You're discharging back into a skilled nursing facility rather than discharging home.
Okay, so one policy per clinician then?
Yep.
All right. Well, thank you very much again, our special guest presenters, and thank you all for coming.